All right, welcome everybody to our Rush Generations lecture. I am Jasmine Chandy. I'm the program coordinator at Rush Generations. For those of you who might be new to Rush Generations, or if this is your first lecture, welcome. We're so happy to have you. Today we're going to have our lecture on back and neck pain. So we have multiple lectures every month. We have workshops, fitness classes, support groups, and tons of great programs with Rush Generations. So we'll give you some of our updates on upcoming programs towards the end of the lecture. So again, for those of you who may be new to Rush Generations, we're a free health and wellness program that's all about aging as best as we can. And so today we're really excited to have our back and neck pain lecture. And before I introduce our speaker, if anyone has any questions, so for those of you who have joined in on YouTube, if you have any questions or comments for our speakers, you can type that into the chat box. So if you've joined in on your computer, you'll see the chat box on the right side of your screen. If you've joined in on a tablet or maybe a smartphone, you'll see that chat box towards the bottom of the screen. So either way, you'll see a live chat button. And so you're welcome to type in any questions or comments you have, and we'll share that with our speaker at the end. For those of you who have joined in over the phone, at the end of the lecture, we will also have an opportunity for you to unmute yourself and ask your question if you have one. So again, welcome. We're so glad to have you. And without further ado, we're going to go ahead and introduce our speaker. Our speaker for today is Dr. Sol Abreu-Sosa. She is an assistant professor in the Department of Physical Medicine and Rehabilitation and the medical director for acute inpatient rehab at the acute inpatient rehab unit at Rush. She was born and raised in Puerto Rico, completed her undergraduate studies at the University of Puerto Rico and medical school at Ross University School of Medicine. She completed her residency at Rush University Medical Center from 2008 to 2012. She practiced PMR in Puerto Rico from 2012 to July 2018 and moved back to Chicago in August of 2018 to work at Rush. So we'll go ahead and get started with our speaker.
Thank you, Jasmine, for that introduction. Yes, I moved back to Chicago and no family here, but I really loved it when I was a resident. So Chicago became my second home, and now I'm here with my family. Thank you for having me as part of Rush Generations presenter, and I will love to share with you a little bit of what I know of neck pain and lower back pain. So I decided to name my lecture pain. Just I think is my screen already shared, Jasmine, or no?
And not yet.
Now,
Okay, now we can see it. Yes.
yes, and because I you guys will understand as soon as we move along the lecture. But neck pain and in lower back pain are actually two common areas of the spine that generate a lot of pain, like the lecture says. So let's just start a little bit of by defining what is pain. Pain is a noun, and I think I skipped. Yeah, sorry. My objectives. By the end of this lecture, I want everybody to understand, recognize the signs and symptoms of pain, and in particular, neck pain and lower back pain. And I will give you all the tools so that you can implement new strategies to minimize and control pain. So let's start first defining what is pain. So pain is a noun, and it is used to describe a physical suffering or a discomfort that could be caused by illness or injury. Pain is, according to the International Association of the Study of Pain, is an unpleasant sensory and emotional experience that is associated with an actual or potential tissue damage. Um, a lot of patients also might describe pain um, based on the damage done to that tissue. As a medical professional and in the medical diagnosis, we see pain as a symptom of an underlying condition. And we know that pain is what motivates an individual to withdraw from a damaging situation because they need to protect that body part while it heals. And also, it will serve as an experience because you need to avoid what precipitated or what caused that pain. Typically, most pain will resolve as soon as you are removed from a noxious stimulus or environment and the body has healed. But in certain occasions, the body might react in a certain way and pain might persist even though the tissue or the body has healed, or even if we have removed already that offending agent. Furthermore, pain can be divided in, I have four categories here, but the most common ones are two. Is either acute pain or chronic pain. So what is acute pain? Acute pain is a biological symptom precipitated by a nociceptive stimulus. It is self-limiting and is highly localized. Typically lasts 30 days. Nociceptive means something that provokes pain or that causes pain. And chronic pain, it is a disease process where pain, whether it is coming from a physiological stimulus, psychological stimulus, or neurological stimulus, will last over 3 months. So that is really important. Acute is something that happens and lasts for 30 days. And chronic pain is something that goes beyond that and typically needs to reach a level of 3 months or past that. Neuropathic pain is not really a definition or a subset of pain. It's just another, I guess, description of pain. I don't know if I'm making sense, but if the tissue is damaged, in particular a nerve, that is when we call it neuropathic pain or has been arising from the nerves. And like I said before, nociceptic pain is whenever there is a damage to the tissue that is causing the pain. And this is just the same thing that I explained, but in a diagram, so that in the first box we have pain, and I'm just explaining a little bit what the image is showing so that those folks that are joining by the phone can follow along. So I have in the first box in the center the word pain, and then that is subdivided in two different categories. I have nociceptic pain and neuropathic pain. Nociceptic pain is pain that arises from the tissue. When any part of the body is damaged or has an injury, we call it nociceptive. If it lasts 30 days, it is acute. And an example of that is postoperative pain. If it lasts more than 3 months, then we call it chronic. And another example for that will be arthritic pain. And then if we go to the other subset, which is neuropathic, then we need to further define it on what is provoking this nerve pain. Is it a stimulus that is provoking it? Like we call that hyperalgesia or allodynia. Those are two medical terms for exaggerated sensation out of proportion. And stimulus independent pain, which is pain that happens all of a sudden, all over blue, and we don't have an explanation to that. So I want to share with you some epidemiological data. Pain is actually the most common reason for a physician consultation in the most developed countries. Its prevalence is as high as 55% of the population, but probably between 30 to 40% of the population might get it. 71 millions of Americans by the year of 2030 will be complaining of pain. And why is this? Is because there's a lot of um, life prolonging therapies now, and the population is living longer. It costs about 70 to 120 billion dollars a year to the healthcare industry. And if we count it as physicians' visits per year, excuse me, I am so sorry. I don't know if I'm gonna keep be able to talk.
It's okay. Take your time.
I suffer from asthma and weather changes. Oh my God. Weather changes and allergies, when they kick in, it's bad. So now it's coming back.
It's okay. Oh, and you're on mute. There we go. Perfect.
I
And
was
we
just
have plenty
saying,
of time.
let's
Yeah.
give it a try one more
Yeah.
time.
We have plenty of time. So take your time.
I guess we can, continue. So 14% of prescriptions that are generated in physician's office are due to pain-related issues, and it cost the industry 50 millions of dollars that are lost per days that are lost in from work. Oh, sorry. Here we go. There was a study done in 2019, and 20.4 of all adults had chronic pain. I think it will be better if we switch to this graphic here. I know, Jasmine, you're trying to help me. Thank you. I see you popping in and out. So the green bar that you guys are seeing on the screen, and for you that are joining in the phone, represents females. The blue will represent, the light blue, sorry, will represent males. And the darker blue is like an average between females and males. So this graphic is just to show you that females suffer most commonly from chronic pain, from a 21.7% in comparison to 19% of males. And high impact chronic pain is just defined of how long this pain will last for the next 3 months. And again, females tend to have pain lasting longer than males for about 8.5% in comparison to 6.3% in males. The prior slide that I skip is just because my voice is not cooperating. It also mentioned that Hispanics tend to have more complaints of pain in comparison to non-Hispanics. But this trend will change or shift if you're 65 age and older, which is the population that I am addressing today. So chronic pain was still high in all of those patients that are 65 years of age and older. Again, females have 21.7% of pain, and non-white Hispanic adults go with 23.6%. In those of age 65 and over, then it shoots up to 30.8%. And in comparison between males and females, typically, again, one more time, females above the age of 65 tend to have more pain complaints for about 11.8%. And this data was taken from the National Institutes of Health and the World Health Organization. So this next slide that I'm presenting is just basically summarizing what I've been trying to tell you. I don't know if my voice will continue to cooperate to the end of the lecture. We'll keep going. That same study published not only that females are more common to complain of pain, females tend to have chronic pain last more than males. Those in age 65 years of age tend to complain more of pain in comparison to males. And also, if you live in a rural area, you have about 28.1% of complaints of pain and actually seeking healthcare just for pain related. And that tends to decrease as we move into a large central metro area. I think this could be for many reasons. One of them is that I guess in urban centers, maybe patients are more prone to stay in on top of their follow-up appointments with primary care physicians or specialists, and or they are more aware of how to learn to recognize when they have pain and how to treat it. In a rural area, maybe because there's not a lot of access to healthcare, they tend to wait longer so that and they tend to seek help a little bit later. Therefore, their pain just, escalates. So let's talk a little bit about what is the function of the spine. Now that we have discussed a little bit of pain and what acute pain and chronic pain is, and how it could be nociceptive, which is a tissue damage, or it could become neuropathic, which is a nerve that is being injured. So the primary function of the spine, which can be subdivided into cervical spine, thoracic spine, and lumbar spine, is actually to provide mobility, to provide support, to provide protection of the spinal canal and all its neural structures. It also transfers loads all the way from the head to the trunk and pelvis. And we have 24 vertebrae that will articulate with one another to allow for motions in three planes. Mostly, these are flexion and extension and rotation. As part of the spine, we also have disc and we also have ligaments, and they will provide intrinsic stability. So stability coming from the inside of our bodies. And then we have muscles to provide extrinsic support. So in these two diagrams, I just wanted to make a very obvious point that we are composed of many layers. And one of our deep layers is just the bone, which is the spine. And as we layer it up with the discs, the ligaments, and the bones, we actually have our full complexity of what the human body is. So keeping in mind that the spine will not only provide mobility, stability, but also will transfer load, we need to start talking about where can things go wrong and where can we start generating pain. So let's first talk about cervical spine, or in this case, we are naming it neck pain generator. Nearly 2/3 of the population will experience pain in their neck. or in their cervical spine at one point in their life. At any one time, about 5% of that population will cause or will have sufficient neck pain to cause a disability. And the majority of that neck pain is muscular in origin. So if we go back to the previous slide, you see that that is the most superficial layer that we have. Of course, there are many layers of muscles that go from superficial and deep. Um, and if we don't treat or if we don't recognize what is the muscle generating pain, then we might be in trouble. There was a study done in 2010 that was trying to identify um, if neck pain was a leading cause of disability in the world, and they found that it was actually a fourth leading cause of disability, just behind back pain, depression, and arthralgias. And what is arthralgias? That is actually a word that we use to describe pain in every single joint in the body. The prevalence of neck pain is typically between 15 to 50%. It's higher in females and peaks in the middle age. And it is also associated with headaches, back pain, arthralgias, and depression. If we remember 5 minutes ago, maybe less than that, that I was talking about the study that the NIH did. And they mentioned that pain, just broad uh, pain, not really dividing it between the spine or the spine generator. If you remember, I said that females tend to have higher complaints of pain, and it was more towards the age group of 65 years and older, and typically a chronic pain, which is a pain that will last more than 3 months. So again, the study that was done in 2010, I know is a lot older than the one that the NIH did. It also mentions the same thing, that the females tend to have more pain, that it will peak in their middle age. And but now they're talking about some other associations, which are headache, back pain, arthralgias, and depression. In the lower back, we know that by the age of 20, 50% of the population seem to have experienced lower back pain. So it tends to come quicker than neck pain. By 60 years old, the cumulative incidence is greater than 80%. And in the beginning of this lecture, I mentioned that pain is actually one of the leading causes of people seeking treatment for their medical professionals or their primary care physicians. But in a recent study, and if all of you guys go right now in Google or in the internet and you just type leading cause of visits to primary care physicians, you notice that it comes up as the second most common reason why patients tend to seek help from primary care physicians. The first thing is actually common cold. Or the flu, and nowadays COVID-19. So why are we talking about pain, right? Who gets it? Is there any of us that won't need to worry about it? Maybe we might not suffer from it. But the truth is that anyone might experience pain in any part of their lifetime. There's a lot of associations of pain. And I say this because it's not only, you don't need to have pain because there is a physical trauma to your body or to your tissue. There's a lot of patients that have psychopathological conditions. For example, they have depression, they can have anxiety, they can have poor coping skills, and we call all that somatization. So patients that may have a lot of stress, when they come to see me in the office, they always complain of pain in their neck and they hold their head. as if that they couldn't deal with it anymore. And through the interview process, you get to ask a lot of questions. And one of them is, if they ever had a trauma, any injury, or any fall to their necks. And they say no. And then as you get to know them, they kind of start sharing with you their life stressors. And that is considered a generator of pain. Traumas like sport injury, if from wrestling, from ice hockey, from playing football, from having a whiplash injury, if you're involved in a motor vehicle accident, or from having a traumatic brain injury, which is any trauma to the head, can also cause pain in the neck or in the cervical spine. And there's also associations with um, work related injuries or occupations. For example, office workers, computer workers, manual laborers, even healthcare workers. Why? Because even this past year, since we've been dealing with the pandemic, a lot of things have moved now to being online and like we're doing today. And we tend to have bad posture. And so we will move our neck or cervical spine in different ways, and we will overstretch in certain muscles, and we will tense up others, and that will create pain. But for the lower back pain, we also need to always be mindful of compression fractures. And this could happen with either a fall or from conditions like osteoporosis, malignancy. There's a lot of cancer that will have metastasized to the bone, or in particular to the lumbar spine, whether it is like I said, lumbar or lower back, or it could be the thoracic spine, which is a little bit higher. Autoimmune conditions, your rheumatological arthritis, your other inflammatory conditions of muscle and joints, for example, lupus, you have Sjogren's, and a few other more, which I probably won't have time to keep naming all of them. And arthritis, your simple osteoarthritis, your wear and tear, your degeneration of your bones and joints will be also a pain generator or will cause pain. So now moving a little bit more deep into the spine pain mechanism. We talked about what is pain, right? And the definition between acute and chronic, or the differentiation between acute and chronic pain. We talked about what is nociceptive pain and what is neuropathic pain. Nociceptive is an injury provoking to the tissue or to the body, and nociceptive is just nerve, that is nerve pain or nerve generated pain. But when we talk to the spine and all the I guess the body functions that the spine does, like flexion, extension, rotation, and just connecting one part of the body to another, we need to talk also about other things associated with it. When we talk about mechanical spine pain, we're talking about bone pain. And where could this be coming from? We have areas of the vertebrae called facet joints. We have discogenic pain, which is our disc. And we have our typical myofascial pain, that in other words, that means just muscle pain. When we talk about neuropathic pain, as I mentioned previously, is a nerve associated or provoke condition, right, causing pain. We need to further divide it into peripheral nervous system, or this is something coming from the central nervous system. Some other times, if we take away the pain that is being generated from a metastatic disease, right, we need to talk about refer pain from another organ. For instances, or for example, when patients have pain in their gallbladder, they tend to feel it up in their neck or just behind the scapula. I think it's the left scapula, and that is typical pathognomonic sign for a physician to recognize that something is happening to the gallbladder. When there is pain in the heart or patients are having a heart attack, they tend to describe pain in the left side of the chest that radiates down the arm, which is something that I guess from education, a lot of people now know nowadays that if they're having that type of pain, they need to immediately go to the ER or to the nearest primary care physician that can see them. And at times there is something without or conditions that could become intermixed. People can have a double trauma or a double whammy, meaning they can be having mechanical pain and at the same time suffering from neuropathic pain. With this picture, I wanted to show and describe, I guess, the beauty of our body. We are looking at a disc and we're looking at facets in the spinal cord. And those of you that are able to see the image are probably thinking, great, but I don't know what that means. So I'm just gonna circle them for you. This round image that you're looking at, or what I'm pointing to, this will be your disc. The second part that I'm pointing at now, that is your facets. And in the middle, we are supposed to have our spinal cord. So basically, any of these three can generate pain. And only a physician that is trained to recognize this will be able to tell you what is happening and where is this pain coming from. I think we have already talked about this, meaning, when their pain is acute, it typically lasts no more than 30 days and then it will resolve mostly within 2 months. And but there are some other patients that tend to have more pain and it can recur even after 1 year. Treatments that we're going to talk a little bit later today will alleviate pain in most of the cases, acute pain. But when is chronic pain, or when there's older age, you have assigned a female sex at birth or you're female, and you have other coexisting psychosocial pathology like depression, anxiety, you might suffer from pain longer. So it's important that we educate our patients on what type of pain they have and what they need to do to prevent this pain from ever coming back. And if their pain is associated with what we call radicular pain, which is a pain that is not only generated in one of those intrinsic or extrinsic parts of our bodies, but is also associated with a typical nerve-related injury, they might have more pain than usual, and it can be difficult to treat. I decided to put this slide about the psychological issues related to pain just to make another point that like I mentioned earlier, depression and anxiety will affect pain, and the patients might tend to feel that they're helpless, that they don't have enough coping skills, and that is the end of the world. And they might see their pain as being severe, but it might not be that severe. It could also damage their sleep. It could also interrupt their circadian rhythm, their external temperatures. But I think if we don't control the pain, that will lead to insomnia, and that will lead to just this biofeedback mechanism that will not stop, will not stop. So in order to get a better sleep, we need to treat the pain. So again, is this is just to prove a point that pain is really um, a difficult entity to understand, to um, to provide guidance to, and also to treat. So if we just subdivide it again into categories, we have physical pain, we have nerve pain. And if we go back to mentioning physical, this could be coming from the bone, this could be coming from from a ligament, this could be coming from muscle, nerve pain. This could be your psychological system, meaning you could have just bad depression, anxiety, anger, and that is provoking pain. Um, so I love what I do as a physiatrist because we get to not only understand all those types of pains and learn to recognize them, but we also work together with a team of specialists that will help us achieve our goal, which is controlling the pain. So we typically work together with the physical therapy team, occupational therapy team, with anesthesiologists, and even with a clinical psychologist. And why do I mention that? Because as I've been talking about for the past few minutes, pain is layered. So we need multi specialists to help treat the root cause of pain. So when you come see a physician like me, physical medicine and rehabilitation specialist, we do take a thorough history when we need to discuss certain factors and qualities of pain. We need to discuss when the pain started, where is it located, how bad is it hurting, how is it affecting your activities of daily living, like dressing, bathing, eating, cooking, doing your household chores, and if this is affecting your sleep or any psychological events that could be related. After we do our history, we need to talk about, a differential diagnosis. We typically refer patients to get imaging studies, whether they are X-rays, MRI, CT scans, and we come with treatment plans. Most of you, when you go to the hospital or attend a meeting with your primary care physician, if you're going to talk about pain, they typically ask you, so can you rate your pain from 0 to 10, 0 being no pain and 10 being the worst possible pain? So I put those two, I guess, pictures so that you guys can follow along and see what the pain scale looks like. In the bottom picture, I have a visual analog scale, which is typically used in kids or those that have health that don't have any education, that have poor literacy, so that they can pick to the face that really describes or how they're feeling. 0 will be a happy face. Number 4 will be a face with semi smile. Our 8 will be a sad face, and a 10 is a sad face with tears coming down their faces. This next slide is just to again point other behavioral approaches that we might have to pain, and I don't remember why I put it there. I think it was because to remind myself that our psychologist friends are always available to help with biofeedback treatment and with psychological therapy. We've talked about this again in our evaluation of pain. We need to take a dedicated history, perform physical examination, and use our diagnostic tools so that we can pinpoint where this pain is coming from or what is generating pain. whether it is in the cervical spine or in the lumbar spine. These two diagrams just represent what we do when we start examining a patient that comes to our office with either cervical spine pain or lumbar pain. In the picture on the right, we're seeing just mainly lumbar range of motion, and that is flexion of the spine, extension, rotation, and the neck does the same thing too. It does flexion, it does extension, it does rotation, and it does lateral bending. And I was going through those motions in the video. There was anyone seeing me. Um, we can also look at then the picture on the right. They're moving the legs, right? And you probably think, why are we moving the legs and examining the legs or moving the arms if we're just talking about the spine? Well, believe it or not, the muscles of the legs and the muscles of our arms, they are innervated from nerves, and those nerves that are actually coming from the spine. So it's really important that when we check a cervical spine, we need to check the arms and hands. When we're talking about the lumbar spine, we also need to check the mobility of the lower extremities or the legs. That will help us pinpoint if there's any particular weakness along a pattern or that follows a pattern for a particular nerve. In this other diagram, I just wanted to point out to certain posture changes that we can see when there is any pathology, whether on the cervical spine or the lumbar spine. So in the picture on the right, we're talking about torticollis or certain positions of either flexion, rotation, or extension of the cervical spine. And on the picture in the left, I might be confusing them from left to right, but the one, if there's anyone looking at either YouTube or live through Zoom, you can see in the gentleman standing that there's a sway back, there's a lumbar lordosis, thoracic kyphosis, forward head, and what a good posture will look like. All of these, believe it or not, will help a physician determine where the pain is coming from and what could be the possible injury. This diagram also highlights this. This is another diagram that just pinpoints what I said earlier about how it is important to examine the arms and the legs when we are talking about a spine pathology, because the nerves really come from the spine, but that eventually comes from the brain. Diagnostic studies. Let's say you came already to see me, you're one of my patients, and you have issues with your back that is radiating to the thigh. And I say, oh, this could be coming from your disc, and this could be impinging on a nerve root. So let's order some MRIs or a CT scan of your spine. So this picture that I'm showing you is to highlight what we could see or what we can find on imaging studies. Again, an imaging study is just a tool to confirm what we have already found in a physical exam. This could also lead to potential treatment options or guide us and what to do next, meaning, is a physical therapy absolutely needed, or do we need to move to a surgical intervention, so those type of things. In the first picture is labeled by letter A. I see a round, it's a sphere, is black, and is rounded. That is a disc. Below it, there is another circular area, very bright, well defined, and that is representing your spinal cord. If we move to the figure on the B side, if we look back at A, we notice that the sphere that is black is a little bit bigger, and all of a sudden the bright center where the spinal cord is smaller. So we will start calling this a bulging disc. And then when we move to letter C, there's basically no space left in the middle portion where the spinal column should be. So this is a herniated disc that is impinging on the cord, and we call this spinal stenosis. On the opposite side of that image, we will see what it looks like in a side view image of the spinal cord, and how the disc is just moving back and is impinging a little bit on the diameter of the spinal cord. We typically don't use one simple view to diagnose spinal stenosis or a herniated disc. We tend to see it side to side, from side view and then from a central view. This is another picture to highlight again impingement on nerve root that is exiting. This is a side view of the spine. I'm pointing right now toward the nerve roots are supposed to be exiting, and how I lose signal in certain areas. So when I lose signal in comparison to the others, that tells me that there is a nerve that is getting injured or impinged. And if we look at it a little bit further, you see how the spine degenerates over time and how certain structures collapse. So now that we've talked about pain and we define pain, we talked about possible pain generators, and we talked about what the function of the spine is, and how a thorough history can pinpoint where this pain is coming from. We could feel ready to talk about potential treatments, and talk about what to do to further help when there is pain. So, according to the World Health Organization, the first approach of pain treatment should be non-opioid medication. So what is that? That is your acetaminophen, your ibuprofens. They're non-steroidal medications. Again, it's really important for everybody to understand that this is just a guidance established by the World Health Organization, and it will work better if it's given by a physically trained doctor, or like a primary care physician, or even a physical medicine and rehabilitation specialist like me. And there's a ladder because we need to follow some steps when we are ready to talk about treating pain. I am non-surgical doctor, so the treatment options for pain that I have will be related to medications and physical therapy and exercises. Some other colleagues will do this, and they will also implement interventional pain like injections or mini procedures. In this image here is just to highlight how different medications work in different tracks in our systems, and why we use different medications to treat pain. If we have pain that is coming from the bone, if we have pain that is coming from muscle, that could be coming from muscle. And if we have pain that could be coming from nerves, we need to have different medications to treat those types of pains. And at times the three of them are combined. They can come together. Um, and I also mentioned antidepressants because if the pain is more so generated by depression or a feeling of sadness or anxiety, it's also completely understandable. and reasonable to treat that type of pain with by controlling your symptoms of anxiety and depression. This is just a medical chart to describe again all the medications available to treat pain that are non-opioid and are just simple safe medications, if we can call it like that. Acetaminophen, ibuprofen, cyclooxygenase 2, and that is your meloxicam or your Celebrex. All of those have good quality, they're consistent, and they're patient oriented, and they are the first line treatments of for pain. The same thing in another table, just to compare different, I guess, formulations, frequencies, milligrams, and how much it will cost. But let's say we try that and none of that works, right? Some patients are good with just taking 2 Tylenols and then pain will disappear, or with taking 1 ibuprofen, but others are not ready and they need to move into another step. So now we go to step 2. And this is when we need to start thinking about recruiting pain medications for muscle pain or for nerve pain, or even introducing opioids, which are high. How would I say this? They're a difficult topic nowadays because of not only how addictive they are, but also because their side effects, especially in those patients older than 65 years of age. Um, Hydrocodone and oxycodone are one of the 2 most commonly used opiates in the United States. They come in a form where you can use it with Tylenol or acetaminophen, I should say, and their brand names could be Norco or Lortab, and they're used in combinations because different studies throughout the years show that the combination of the 2 of them will treat pain in a different way. They go through a different mechanism in the brain pathway and in the spinal cord, and you will have analgesia, which is a pain relief in a faster way. Since the year 2011, the FDA recognized that having acetaminophen available with an opioid it was something dangerous because people would take more medications than recommended, and if acetaminophen dosing was not controlled, that could lead to liver failure and kidney failure. So since the year 2011, they have a black box warning in those opiate medications that are combined, that each unit cannot have more than 325 milligrams of acetaminophen available, because we want to avoid hepatic injury. And those that you buy over the counter that don't require medication, a prescription, the maximum amount of dose of acetaminophen that you can get will not be greater than 4,000 milligrams per day. So in a period of 24 hours, you shouldn't take more than 4,000 milligrams of acetaminophen. Let's say we really need to use opioids in our geriatric population because there is an acute pain from a big trauma, a big fracture, or even a surgery. Let's say a gallbladder needs to be removed, or an appendix, or perhaps, I don't know, an ulcer that needs to be repaired. It is okay to use an opioid, but we need to make sure we are using the opioids for a certain amount of time, and we need to differentiate a short acting opioid versus a long acting. So a short acting opioid will be good for acute pain and breakthrough pain, But when there is pain associated with more chronic and perhaps life-changing events, for example, a cancer-related pain, we typically like to have long-term acting opioids on board so that the pain can stay at bay for longer periods of time, and that the patient will need to start using medications every 4 to every 6 hours. This picture here is to highlight that opioids come in tablet forms, they can come in injectable forms, and they can also come in patch forms. All of them have different half lives, which means that they last shorter or longer in the body, but this is just based on their formulation and what type of route we are using. And your physician, whether it is a primary care doctor, a pain specialist like anesthesiologist, a PM&R doctor, or any type of specialized physician that is in charge of treating your pain, that will be the one that you can discuss what will be, if needed, what will be the best opioid that they can use for your particular condition. Again, this is not first line treatment. The first line treatment for pain is your nonsteroidals and your acetaminophen. Side effects from the opioids: itchiness, sedation, nausea, respiratory depression, constipation, etc., etc., etc. There's a lot of side effects that comes with the opioids use. They're not really um, they're not the greatest, and physicians really tend to avoid using opioids. We only use it as needed because we know that they all come with side effects. They're typically medications that we could give to revert some of those side effects or to control it. And nowadays, it's really important for all healthcare personnel to be trained on how to use Narcan, which is a medication that will revert the effects of opioids. For the sickness of time, I'm just gonna move through a little bit quicker about certain, just mentioning that antidepressants are available to treat chronic pain, and we call that adjuvant therapy. So this will be our step 3 in that ladder of pain treatment, according to the World Health Organization. So if your step 1, that is your acetaminophen and your ibuprofen, if they don't work, then you might move to step 2, which is perhaps adding an opiate. And your step 3, this could also fall into a little bit of 2, is adding your antidepressants. So medications like Cymbalta, like Effexor, nortriptyline, amitriptyline, all of those medications can help with pain. If the pain is coming with, if there's a pain component associated with a nerve injury, and the patients complain of numbness and tingling, of shooting, burning pain, radiating pain, we can also start medications like gabapentin, like capsaicin, like Lyrica or pregabalin. Those are approved medications by the FDA to treat nerve pain. And muscle relaxants, like baclofen, tizanidine, and benzodiazepine. Baclofen and tizanidine are the most commonly used in geriatric population because they tend to cause, they're the less sedative. Benzodiazepines, they cause a lot of sedation. We use it in the rehab world because of our patients that have spinal cord injuries. It's a very well tolerated medication in that population. When all medications fail, and even physical therapy, which we're going to talk in a little bit, we can talk about interventions, like doing a nerve block, doing a peripheral nerve block, doing epidural steroid injection, facet blocks, just something more invasive, to be more proactive, and I guess to treat the pain more locally and have less systemic effects. That is the beauty of interventions. And our bread and butter, rehabilitation exercises. So we can refer patients to physical therapy and occupational therapy. And our goal is to improve function, mobility, transfers, and the abilities of daily living. We also want to decrease pain, and we also like to do some stretching and strengthening of certain muscles and muscle groups. And this could be done in different settings. This could be done in the inpatient world, in the outpatient world, at home, and even with the use of telemedicine, because now with the pandemic, we have become experts on using telemedicine. And even for therapy, they're doing it. They're doing it. Um, Cryotherapy, what is that? Is the use of cold and ice to decrease spasticity and to relieve pain. Heat therapy works too because it reduces the muscle tone and it provides analgesia. TENS is another really good method that the therapy team will use. Very popular 15 years ago, maybe more than that. Nowadays, people tend to forget that we can use TENS to relieve. It's a little device, looks like a Walkman with some patches. You attach it to the skin and you control the current that is going through those patches so that it can provoke analgesia. Acupuncture. I have two of my colleagues that do acupuncture in office to provide pain relieving techniques. And our last few slides are just stretches that I provided. I wanted to do it with the group all together, but I don't think we will have time. I can demonstrate a few of them. So when there is cervical pain, and especially nowadays that everybody's using the computer, our phones, and even being sedentary, we tend to have a lot of pain in the anterior portion of the neck as well as in the back, and that can be associated with headaches. So how do we relieve that? We need to open up our cervical spine by stretching our scalenes, right? Our we can also stretch our sternocleidomastoid, which is another just different muscles that I'm naming here. And but if you're able to see the diagram, you can follow along. Um, all those stretches should typically be held in position for about 10 seconds to get the maximum relief. And these are some from for the lower back, whether it is gluteal stretch, whether we're doing our lumbar muscles, whether we are doing a torso twist or cat and cow pose. All of those will just move the spine and so that we can get mobility and we can have some pain relief. Pilates, yoga, tai chi, relaxation techniques, mind body medicine, all of that works. All of that works. So if we have the opportunity to be to treat any patient with pain, we do a thorough history. We diagnose what kind of pain they have, whether it is acute or chronic, whether it is nociceptive or neuropathic, whether it is coming from the bone, from the muscle, from the nerve tissue, how is it affecting their body, and how we can restore function. We can do this by a combination of different things: physical therapy, exercise, medications, whether they're orally, via patch, via injections, maybe interventions, and maybe by changing our lifestyle, whether it is implementing Pilates, yoga, relaxation techniques, Tai Chi. The goal is to utilize all the available tools that we have in our bags and all the other specialists that will help us treat pain so that we can make a body function again and pain free, which is our goal, right? um, in conclusion, the quest to relieve pain and suffering has always challenged the humankind for centuries. We need to have an approach biopsychosocial, um, mainly because we need to understand what we're dealing with and how to treat it. And that is the most sensible way to approach this difficult topic. Um, and this is not going to a doctor is really not a one-stop shop, right? A lot of the times as specialists we need to recognize what our strengths are, what the limitations are, and it's always better to work in conjunction with other specialists as a team so that we can together provide the best support that the patient might have. And this is how you can get a hold of any of the doctors in the physical medicine and rehabilitation um, service line at Rush University Medical Center. Um, there are about, let me see, one, two, three, four, five of us doing mostly outpatient therapy, not therapy, rehabilitation services and evaluation, and three of us that will do mainly inpatient, but we also have outpatient services available. Again, I thank you very much for this opportunity. Um, I'm sorry that I lost my voice initially, but it came back. Maybe it was a little bit too, I don't know, abstract or too medical, but my goal was to educate each one of you that it doesn't matter if we're talking about neck pain or lumbar pain. As a rehabilitation physician, I will look at it as a spine pathology, and the spine will actually function to provide movement, support, protection, and to integrate the body as one unit. So it was important for me that everybody understood what it means to have different pain generations, what it means to have different subset of pain, and how a physician like me could help all of you travel this pain enigma, and because it's still a lot of changes that will come forth throughout the years. So thank you very much. I will open the floor to any questions.
Thank you so much. And I'm really glad your voice came back. And thank you so much for trying your best to push through that. The whole lecture, I couldn't even tell that you had that happen. So thank you so much. We do have a few questions already online. And then before I get there, I just love that you mentioned the biopsychosocial approach to managing pain. I think that's so important. And so in a few minutes, when we discuss our upcoming programs, I think you'll be able to see that there are opportunities for you to help manage your pain in different ways. So before I read the questions that are online, I want to first open it up for those of you who have joined in over the phone. If you have any questions, you're welcome to unmute yourself now and ask. And to unmute yourself, you can press *67. Hello. Hi, did you have a question?
Hello?
Hello.
Oh, thank you. Yes, I have quite a remarkable story. I'm 80 now, and about 30 years ago, I was needing to help a very precious, lovely, lovely dear parent out of the bathtub who stubbornly decided to get off the bath chair and soak in the bottom of the tub. Well, she had no strength and no understanding, and I got her out, and I was thrilled. But I had, from the experience, 2 herniated discs. I was on Vicodin continually, on crutches. They wanted to do an epidural. The orthopedic guys. I didn't want that stuff in my body, but I was a little stubborn also. I didn't want surgery, which they recommended. I had 2 very dear friends who installed a grab bar in the threshold of an upstairs bathroom, just above the tips of my fingers. Well, I've lost a little height since then, so I stand on my tiptoes. At that time and every morning and every night, I hold on to the bar, I go limp, I wiggle a little bit. The herniated discs went back in place years ago and have never bothered me. Now, I think that's amazing.
It is. And thank you for sharing.
Yes,
A lot
yes,
of I mean, I do typically recommend my patients to um, to follow a stepwise approach, meaning if we have done a thorough history and a physical exam, and the image that I order that I'm seeing is not something emergent that
yes,
needs surgery right away. For example, having image, right? In your particular
yes,
case, they told you it was a
yes,
herniated disc, but if you didn't have any weakness, bowel or bladder incontinence, if you were able to move your legs, show that the nerves were still there and there was nothing impinging those nerves, or perhaps surgery was something that could be hold off. So
yes,
with exercise and with a good medication regimen, we could have controlled this. And I'm glad that you started moving, because there's nothing better
yes,
than move
yes,
around to feel better and to move things back into place. So
yes.
good for you.
Yes, it occurred to me that it was a type of traction that people often have in the
Correct.
hospitals for this kind of a thing. But the fact is, it was so terrible that I was on crutches, and it ended in also some um, sciatica pain down my leg. It was atrocious, but that was a remedy. I don't suggest it for everyone, but of course, with medical help, and the doctors were amazed. So thank you for listening, and thank you for your very complete and explanatory lecture. I appreciated that. Thank you.
Oh, you're more than welcome.
Thank you.
I didn't really mention, assistive devices that we at times use, like cane, walker, crutches, or even wheelchairs, because I thought I was just gonna, steer away from what this lecture was all about. But at times, if they're needed and they're recommended, use it. Is for your advantage from preventing falls and get you to move better.
Thank you. And thank you so much to whoever asked the question. I love that story. And we'll go ahead and start asking some of our online questions. And then after I finish reading these four, for those of you over the phone, I'll give one more opportunity to unmute yourself. So if you had a question, you're welcome to prepare it now. So the first question we have online is if you could describe chronic pain again.
Yes. So there are two main types of pain. Acute pain is pain that happens automatically after an injury, nothing more than 30 days. Chronic pain is something that lasts longer, between 6 weeks to 3 months. So if you fall into that category, by definition, that is a chronic pain. So it's more than, let's say, 45 days to 3 months. So anything between that and greater, that will be chronic pain. We're steering away with what was called subacute. In the past, they used to call acute, subacute, and chronic, but there's really no point of dividing them that like that anymore. So 30 days or less acute pain, 30 days to 3 months or up or after that, then it will be chronic.
Nice and clear. Thank you. The next question, does pain that is caused by muscle spasms in the frontal part of the leg or thighs indicate thoracic spine issues? Let me know if you want me to read that again.
No, it is a great question. So the simple answer will be yes. Most likely, when the majority of times when there is pain in the anterior portion of the leg, that will indicate, until proven otherwise, that there might be a spine pathology. Typically, the anterior portion of the thigh, if it's closer to the groin, that is around L1 to 2 area, If it's in the middle of the thigh, that will be L3. And if it's going all the way to the knee, that will be L4. So if it's not the spine that is causing this, then we'll move to a localized muscle. There are plenty of muscles in the thigh, but it requires a specialized physician, like orthopedic surgeon or like a physical medicine and rehabilitation specialist like myself, to kind of pinpoint where this pain is coming from, or neurospine surgeon. Yeah.
Thank you. The next question we have online: what would you evaluate in the arm and hand for neck pain?
Another really good question. So the body or the spine, they form dermatomes and they form myotomes. Dermatome is an actual area of the skin that is associated with the level on the spine. And a myotome is a muscle in our body parts that is also associated with spine level. So for simplicity, our biceps muscle here. So your ability to flex and to show how big you are, this is actually C5. This is your biceps muscle. So if you have numbness and tingling around this area, and then you also have weakness with giving me your full power, I can tell you that there's something wrong in your C5 level, because you have lost sensation and loss of muscle strength. I also need to corroborate that with other muscles that come from the same area, or C5 innervated area, which are my deltoid, which is your ability to move your shoulder up and down. So let's say you can't really lift your arm and you can't really make a big muscle, but you can move everything else. I know for sure that there's something in your C5 level, and it's not related to an individual muscle. In the hands, we have, this will be your C6, this will be your cervical level C8, and C7. Yeah, C7 actually is triceps, sorry, so it's triceps. So that's why when we are checking the cervical spine, we check the arms, and we're checking the lumbar spine, we need to check the legs.
So interesting. And then the last question we have is there an optimal way to sleep to manage back pain?
There are a few actually. Typically sideways with a pillow in between the knees. That will keep your pelvis in neutral. Another recommendation is to actually don't put any pillows in your neck. Maybe a towel or a little blanket rolled to make like a cylindrical shape, to give a little bit of support between the neck and the head. That will keep your spine as stable as possible. But there are other people that say, "Oh, buy a really expensive mattress." I don't think that will really make any difference. So if you try different positions, and if you tried the pillow trick and the pillow in between the leg trick and nothing is helping, then it's time to see a specialized physician to help you.
Great. And you are getting a lot of just thank yous and likes from your
That's great.
presentation. So I wanted to share that too. And then the last question we have says, right-sided radiating pain just below the rib cage could indicate which nerves or muscles are involved.
Another excellent question. So most likely is the spine. It's the spine in the thoracic area, which is, let me move a little bit back. If there's anybody that is watching me at home, so it's here, right? So this is the rib cage. If it's underneath, which is where the ribs are, if it's radiating back, it could be either your thoracic spine, it could be your ribs, it could also be your chest. A lot of patients, when they have pneumonia or they have any pathology, whether it is in the heart or whether it is in the lung, it could radiate to the outside and it will give bone pain. So it's a difficult question to answer because I need more history. I need to really do a hands-on physical exam, but that could be the possibilities. Well, those could be the possibilities, I should say.
Great. And it looks like, okay, great. People are grateful that you answered their questions, and that's all of the questions online. And before I start to share some of our upcoming programs and to wrap up the lecture, just want to give one more opportunity for those of you who've joined over the phone. If you have a question for our speaker, you can ask now. And again, to unmute yourself, you can just press *67. All right. I think that's everything. Thank you so much once again for your presentation and for answering all of our questions. We really appreciate it.
Thank you. Thank you for inviting me and for having me over. And I'm glad that everybody, followed along and gave me time to recover.
Of course. Thank you. And for all of you who have joined, we're going to go ahead and share some of our upcoming programs. So all right, so let's get started. So first and foremost, for those of you who would like more information on the vaccine, so whether it's information about how it works, its safety, what exactly the vaccine is, or also to make an appointment, just want to share that that is all on Rush's website. So that's rush.edu. You can get information on how to make an appointment if you haven't already, as well as more information about the vaccine. All right, and next we have our Take Charge of Your Health workshop. So this is a workshop that's all about managing your chronic conditions. So learning how to set goals, how to best accomplish your goals, and learning all these different facts about how you can manage your health. So this will be on Thursdays from April 27th until June 8th from 10 a.m. to 12:30 p.m. So this program and all of our programs will be done virtually, which means just on the computer or over the phone. And so this workshop will be done through Zoom. And so if you're not familiar with Zoom, but you are interested in the workshop, that's okay. Our team members are happy to help you get settled and help you feel comfortable using Zoom before the workshop starts. So if you're interested in the Take Charge of Your Health workshop, you can call our Rush Generations number, which is 800-757-0202. And so I will be sharing a bunch of different programs that we have coming up. And for all of these programs, you can register or get more information by calling that toll-free number. All right, so next we have Tai Chi for arthritis and fall prevention. So this group will be meeting on Wednesdays and Fridays from May 26th till July 15th for just an hour from 11 a.m. to 12 p.m. This will also be done through Zoom. And again, to register or to get more information, you can call the Rush Generations toll-free number at 800-757-0202. We have our Learning to Live Well with Chronic Pain. So this is a group very similar to our chronic disease self-management group. So instead of focusing on those chronic conditions, in addition to that, we're focusing on chronic pain. So how to best manage chronic pain. And so this will be on Mondays from April 12th till June 8th from 3 to 5:30 p.m. This also will be done through Zoom. And again, if you're not familiar with Zoom, that's okay. We're happy to help you get comfortable with that. And so to register for the group, the Learning to Live Well with Chronic Pain, you can call the Rush Generations toll-free number at 800-757-0202. Next, we have WRAP for seniors. That stands for Wellness Recovery Action Plan. And so this is a group that's all about learning how to manage your stress, managing negative thoughts, and doing that as a group. So it's a really wonderful program that's come back. It's going to be on Wednesdays from May 5th until June 9th from 10:30 a.m. to 12 p.m. There's a typo on the screen. And so this will also be done through Zoom. Again, if you'd like to register, 800-757-0202. Next, moving on to some of our fitness classes that are coming up, and all of these fitness classes are done online, so through the computer. And so first we have our chair strength class that'll be on Mondays from March 22nd until May 10th from 1:30 to 2:30 p.m. It is $40 for the 8 sessions, but if you're not able to pay the $40, that's okay. There are scholarships available. So if you're interested in the chair strength class, you can call the Rush Generations number. We also have the gentle chair yoga class. This will be on Thursdays from March 25th until May 13th. This is from 11 a.m. until 12 p.m. Again, this is also $40 for the 8 sessions, but if you're not able to pay for that, there are scholarships available. This is also done through Zoom, and you can call the Rush Generations toll-free number at 800-757-0202. Next, we have our Art for Emotional Wellness class. So this is a really great class where we're having art students actually teach about various art history and art techniques, and then you'll learn how to use those techniques in this class. So it's a really wonderful opportunity, a great thing to do, especially right now. And so this will be on Thursdays from April 1st until April 22nd from 1 to 2:30 p.m. Again, it's called Art for Emotional Wellness. Thursdays, April 1st until April 22nd, 1 to 2:30 p.m. This will also be done through Zoom. And then moving on to some of our support groups that we have our Coping and Connection in the Time of COVID support group. So it's a really great opportunity to just call in. It's a conference call with one of our social workers and to share how you've been managing this time during COVID, what the challenges are, what the stresses are. It's been over a year. And so how you've been managing that, how you've been feeling. It's a really great opportunity to connect with other people. It'll be the third Wednesday of every month from 3 to 4 p.m. And we have the phone number and the access code up, but to get that information, you can also call our Rush Generations number. We also have our diabetes education and support group. This is the third Thursday of every month from 2 to 3 p.m. So this is getting more information about diabetes, also having that mutual support. This is also telephonic, so you can just call in for a conference call with other individuals who are also interested in this. So again, this is the third Thursday of every month from 2 to 3 p.m. We also have our Senior Connections Friendly Caller program. So if you're interested in having someone give you a call once a week, this would be a trained volunteer just to give you a call, friendly check-in whenever you're available every week. This is open to you. And so if you are interested in the program, you can call the Rush Generations number at 800-757-0202. And we have a Rush Caregiver Initiative. So if you're a caregiver or if you have a caregiver, this is a really great opportunity. It's really a customized approach. So it starts off with an assessment, and then they'll determine what the needs are and what would help you at this time. We all know that there's a lot of stresses and a lot of challenges with being a caregiver, and there are resources available. So again, if you're a caregiver or if you have a caregiver and you're interested in the Caregiver Initiative, you can call the Caregiver Initiative at 312-563-0350. And for those of you over the phone, I'll repeat that one more time. That's 312-563-0350. All right, and we're almost there. So second to last, we have our Shaman Senior Voices program. So this is a really great opportunity to learn what matters most to you as you age. And so what we do with this is we actually record video. So in just 60 seconds, you can record a video telling us what matters most to you and how you're staying connected to what matters most to you. And what we do with these videos is we share it with our healthcare students so they can learn how to be a better healthcare professional, especially working with older adults. We also use it for our healthcare providers and also to have conversations in the community around aging. So we spend a lot of time talking about child development and about adulthood, but we don't always talk about being an older adult. And so if you're interested in sharing your perspective and sharing your story, you can record a video by visiting bit.ly/recordmystory. All right, and the final reminder that Rush Generations is with you during this time of staying at home. And so if you are interested in any of these programs or want to get more information, you can call our toll-free number at 800-757-0202. For those of you who use Facebook, we also have a Rush Generations Facebook page. And so on there, we also update it with our upcoming programs too. So thank you all once again. We're so glad you joined us, and we hope to see you at some of our future programs. And thank you again to our speaker, Dr. Sosa.